Good afternoon, everyone. Welcome to today's PQA Quality Essentials focused on PQA statin use and adherence measures. As we do with every Quality Essentials, I'd like to run through a few housekeeping items. First, please submit your questions during the presentation using the Q&A feature located at the bottom of your screen. We'll include your questions in the Q&A portion of the webinar. Also, the webinar recording and slides will be available to PQA members within a week in the Member Resources section of the PQA website. The recording will also be available on PQA's YouTube channel. Last, I'd like to encourage all attendees to please complete the quick 1-minute survey that will appear at the conclusion of the webinar. PQA would like to thank PerformRx for being an educational sponsor for this Quality Essentials. PerformRx is a pharmacy benefit manager dedicated to clinical culture, boutique service, and holistic solutions. Its mission is to help clients, providers, and members use effective medication therapy to improve health and wellness. Thank you to PerformRx for your support of PQA today and throughout the year. You can learn more about PerformRx at performrx.com or by contacting John Butts at johnbutts@performrx.com. Today's presenters are Rachel Digmann, Senior Director of Performance Measurement, Ben Shirley, Director of Performance Measurement, and I am Lisa Hines, Chief Quality and Innovation Officer, and I'm serving as today's moderator. Today we'll focus on 2 PQA statin-related measures, adherence to statins, using the proportion of days covered methodology, and statin use in persons with diabetes. And that's an appropriate medication use measure, which we also call a gap closure measure. Rachel and Ben will provide an overview of the measures and the supporting evidence, highlight measure use and impact, answer some frequently asked questions, and discuss health equity considerations. Last, we'll save some time to answer audience questions that come in through the Q&A function. So now I'll hand it over to Rachel to provide a history of both of these measures.
Thanks, Lisa. Welcome, everyone. Hopefully you're having a good day. We're happy to have you all on our call today. So before we get more in depth with the specific measures, I wanted to take a minute and refresh everyone on the call a bit about the PQA process for measure development and measure maintenance. So if you have been on the PQA, any previous PQA presentation, there's a really high chance that you have likely seen this slide before. This graphic represents the PQA measure development and measure stewardship or maintenance life cycle. And components that you see notated on this graphic include conceptualization on the left-hand side, which is when we identify and prioritize concepts to be developed, specification, which is what it sounds like when we draft measure specs, and conduct initial feasibility testing. Then we move into measure testing, where we develop and execute a comprehensive testing plan and evaluate testing results and measure criteria. And then the last 2 are the ones I think I want to focus a little bit more on here, which is measure endorsement, is when we have member organizations complete their votes on new measures under consideration for addition. And the last little circle you'll see on the right-hand side there is implementation and maintenance, which is where we have our ongoing measure updates, and we ensure that the measure remains current and relevant. So those are near and dear to my heart. It's a lot of what I spend my time doing, and specifically wanted to just make sure that everyone is aware that for measure endorsement, it's important that I think we all recognize that there has been rigorous review by stakeholders and PQA staff, and that the final measure that moves into maintenance does meet all aspects of importance, acceptability, feasibility, validity, and usability. So very important concepts to consider. All right, so we're going to move into our discussion around the proportion of days covered statin measure, or the PDC statin measure, as we refer to it occasionally internally here. So I wanted to spend a little time reviewing the evidence that was considered when the measure was developed, and talk through that a little bit so we're all kind of on the same page. So it's important to note that statins are recommended for the management of dyslipidemia and primary prevention of cardiovascular disease in several treatment guidelines. By lowering LDL cholesterol, statins decrease the risk of cardiovascular disease mortality and morbidity. And although long-term treatment with statins is effective in preventing cardiovascular disease, patients often do not take their medications as prescribed. Numerous studies have shown improved clinical outcomes for patients who are adherent to their medications. Specifically in patients with dyslipidemia, adherence studies have shown a strong relationship between adherence to statins and the reduced risk of cardiovascular events, and also lower overall healthcare services utilization and costs. So lots of evidence to support that a measure that evaluates adherence to the statin medications would be beneficial in evaluating these patients. Next, I want to review some historical timeline of the proportion of days covered statins medication measure maintenance, so related to the PDC statin measure. It's one of the PQA's earliest measures that was developed. It was endorsed, as you can see on this slide, by PQA membership. It was endorsed in 2008. Which to me feels like it was 2 years ago, but really it was a long time ago. And we also had subsequent endorsement by the NQF, the National Quality Forum, in 2009. PQA has since maintained NQF endorsement through 2 additional cycles, including recommendations to risk adjust the measure in the Medicare Part D star ratings program for sociodemographic variables. Also, and we'll talk about this a little bit later, we added exclusions of hospice care and end-stage renal disease were added to the measure throughout the consensus-based maintenance process, and you see that happened right around 2018. Okay, so let's just review the proportion of days covered statin measure core construct a bit. As you can see on this slide, the denominator for the proportion of days covered statin measure is individuals greater than or equal to 18 years of age with at least 2 prescription claims for any statin on different dates of service in the treatment period. As I mentioned on the previous review of the timeline for measure development maintenance, that we did include exclusions for hospice and end-stage renal disease. A little background on that: individuals in hospice care are excluded because the use of statins are meant for long-term therapeutic benefit, as the medications are known to decrease the risk of cardiovascular events. And the therapeutic regimens may not be present at the end of life or useful at the end of life. So that exclusion was added. And then individuals with end-stage renal disease are excluded because evidence from major clinical trials failed to demonstrate benefits from statin therapy in that particular population of patients. And then last, I just want to draw your attention to the numerator calculation, which is similar across most of our PDC measures, is individuals from the denominator who had a PDC or a PDC threshold of 80% or greater during the treatment period. So that's sort of the core construct of the PDC, or proportion of days covered statin measure. And then just a few other key components to keep in mind are that the proportion of days covered statin measure is intended for performance measurement of health plans. So it's specified at that level of analysis. And the data sources that are used to calculate this particular measure are prescription claims, medical claims, and enrollment data. So another key statin measure that we want to draw your attention to is also our statin use in persons with diabetes measure, our SUPD measure. In consideration of the evidence that was available and that was utilized in the development of this measure, I just want to draw your attention to the fact that cardiovascular disease is established as a major cause of morbidity and mortality among patients with diabetes, and similarly is a major driver of cost of diabetes management. So nearly half of all patients with diabetes are not meeting established guideline goals. And a recent review found that the proportion of patients meeting LDL goals, it ranged from 13-ish% to around 76% in a global study. And then the proportion of diabetics meeting LDL goals in just the United States when they evaluated it ranged from 52% to 73%. So significant opportunity for improvement. And I believe Ben will be addressing some of that as well later on. And I just want to make sure that we're all on the same page and understanding that the current guidelines from the American Diabetes Association and the American College of Cardiology, and also the American Heart Association, congruently recommend moderate to high intensity statins to be used as a first-line lipid lowering agent for patients with diabetes aged 40 to 75 for prevention of cardiovascular disease. The benefit of statin use in patients with diabetes has been proven in several analyses of multiple studies involving thousands of patients for both primary and secondary cardiovascular disease prevention. And this is for both type 1 and type 2 diabetics. Statin use in diabetic patients decreases the incidence of cardiovascular events by 21%-ish, and decreases mortality by 9% based on some evaluation of some available literature. So this PQA endorsed measure was created to determine the proportion of patients who were dispensed 2 diabetes medications within a year that also receive a statin medication. So as Lisa mentioned at the beginning, it is a gap closure measure, which is different than a medication adherence measure, such as the the proportion of days covered for statin medications. Now, this particular measure uses pharmacy claims as a proxy for diabetes diagnosis. The reliability of the proxy method was confirmed by independent organizations in partnership with PQA. This investigation that we performed early in the development actually did find that the minimum of 2 diabetic prescriptions was a valid predictor of the diabetes diagnosis. Okay, so let's look a little bit at the timeline for development and maintenance of the statin use in persons with diabetes measure. So as you can see on this slide, the measure was endorsed by PQA membership in 2014 and has had multiple updates and maintenance occur routinely. Like many PQA measures at the time of development and endorsement, the source of measure data was solely prescription claims and pharmacy benefit enrollment. However, over time, additional data sources were included that could be used to refine the denominator population with specific exclusions, which is why, as you're looking at this slide, you'll see that additional updates or exclusions were added to the measure via our PQA consensus-based process to improve the measured denominator specificity and sensitivity and alignment with current clinical evidence. So you can see that in 2017, we added end-stage renal disease, and we started to use medical claims for the denominator exclusions. In 2020, we then expanded and added additional exclusions, including the rhabdomyolysis myopathy, pregnancy, fertility, liver disease, which was later refined to cirrhosis, PCOS or polycystic ovarian syndrome, and prediabetes were considered and added in 2020. And then most notably, recently in 2022, as I mentioned, we refined that liver disease exclusion to include a smaller subset, which is more targeted and supported by the evidence, which is cirrhosis. And we also removed dapagliflozin and empagliflozin from the medication tables used to identify the denominator for the SUPD measure. And this is due to the expanded indications for use that were FDA approved for those particular products. So those single ingredient products were removed from the medication table. Okay, so let's take a more in-depth look at the statin use in persons with diabetes measure. So as you can see on this slide, we do have the denominator as individuals aged 40 to 75 years with greater than or equal to 2 prescription claims on different dates of service for any diabetes medication during the measurement year. Exclusions include those listed on the slide, and I discussed those previously, and the reason for their inclusion. And then the numerator is individuals from the denominator with greater than or equal to 1 prescription claim for a statin medication during the measurement year. So hopefully we're all on the same page with the core components of the measure. And then the other pieces of information to understand about the statin use in persons with diabetes measure are that the intended use for the measure as specified is at the health plan level. So it's a performance measure for health plans. And the data sources we use for this particular measure are prescription claims, medical claims, and enrollment data. So that's a high-level overview of our 2 statin measures. And I do want to go ahead and turn it over to Ben so he can talk a little bit about the impact of the PQA statin measures. So Ben?
Thank you very much, Rachel. Can you hear me okay? Loud and clear.
Well,
thanks so much, Rachel, for providing that overview, and now everyone on the line. I think a lot of you were familiar with them already, but now we know for sure you know how these statin measures are designed and the measure construct and some of the evidence behind them. But what exactly is the impact of these measures, right? So how are they being used? Are they making a difference? We'd like to spend a little bit of time diving into that side of things. So PQA statin measures are very popular in quality programs, given the clinical importance and a lot of the evidence that Rachel just spoke to. So on the left side of your screen here in green, you can see 4 programs that both the SUPD measure and the PDC-Statin measure are both included in. So there's the Part D star ratings, which is likely the best known program, right? So PDC-Statin has been in that program since data year 2010, while SUPD is relatively newer, having been added in 2015. PDC-Statin is triple weighted. It's classified in that program as an intermediate outcome measure. While those of you who are closely paying attention to the rules will know that SUPD has previously been categorized that way as a triple weighted intermediate outcome measure, but is actually moving to a single weight as CMS reclassifies that into a process measure. So beyond Part D, we see use in a variety of state Medicaid programs. So New Hampshire, for example, provides a comprehensive dashboard of performance on a variety of PQA measures, including the statin adherence measure. The statin measures are both used in the Integrated Healthcare Association's Align, Measure, Perform public reporting program in California. So this is a great example of a comprehensive state-level program with public reporting and recognition for high performers out west. And then there's going to be a wide variety of other grants, research projects, quality improvement initiatives, and other applications for these 2 measures. And then in addition, there are a few programs where PDC-Statin is used, but not SUPD. So this is going to include both the Health Insurance Exchange Quality Rating System, which is a public reporting program for individual ACA plans, as well as a variety of URAC accreditation reporting standards. However, just because these measures are implemented doesn't necessarily mean anything on its own. So measures that allow us to record performance of programs of measured entities, that's great. That's really important. But what really matters is the knowledge that we're using these measures to drive improvement in care for patients. And actually, in some programs, we have really rich data on exactly that. So we can take the Medicare Part D program, for example, here. We actually have the benefit of having access to publicly reported data on measures in Part D over time. And what that means is that we can actually look longitudinally at this performance data and look at the changes that we see for both the statin adherence and statin use in persons with diabetes measures. And what we see is that plans have actually made very substantial gains over time on these measures. So looking at the slide here, PDC-Statin saw improvements of almost 20% over the last 10 years. 20%, that's 1 in 5 beneficiaries. That's a really substantial change. And SUPD rather, has improved almost 10% over the last 5 years. Actually, both are improving at roughly a similar rate at an average of around 2% per year, even though there are going to be some fits and starts with performance in any program. But really, when we think about the number of patients in Medicare with these conditions, these types of percentage changes, they translate into massive impacts. And in fact, CMS has actually taken the time and effort to quantify a lot of those impacts. And the results are pretty impressive here on the next slide. Each 3 years, CMS releases a comprehensive assessment on an analysis on the impact of quality measures, which is logically titled the National Impact Assessment. And in 2021, they released the most recent version, and that included an analysis of the PDC-Statin measure, so we're talking about that specifically, and the impact that that measure had between 2013 and 2018 as part of looking at the broader 3 adherence measures, but we'll talk about PDC-Statin specifically. And the numbers they jump off the page. I mean, we're talking about 5.4 to 13.7 billion, as you can see there on the left in terms of cost avoided. So that's going to be costs avoided due to improved management of cholesterol, leading to reduced hospitalization and healthcare utilization. And then 4 million more beneficiaries adherent to their statins compared to where we'd expect to see the adherence rates without these measures and incentives in place. So this really is, it's a great case study on how measurement combined with strong program incentives and quality measurement can result in improvements over time, can create major ROI, return on investment for agencies like CMS, and ultimately create a real difference for these patients as they experience better care, they manage their conditions better, and they have fewer hospitalizations, emergency room visits, and things that we all know we all want to avoid. So the CMS Impact Assessment is a great document. It's a trove of information. It's actually available from the CMS website for those who are looking for it. And we also discussed these impacts a little bit in an article that we recently published, the PQA team, in the Journal of Population Health Management. So if you're interested in that article, which describes the impact of PDC measures and adherence measures from PQA over time, as well as sort of does a little bit of late myth busting and some other education, I highly recommend that you check out the PQA website where you can navigate to the article itself. And now, having talked about the impacts, we'd like to switch gears here a little bit, and Rachel and I will be tag teaming this section, but we'd like to take a few minutes to address some frequently asked questions. So the PQA team, and actually Rachel and I specifically, we do provide comprehensive technical assistance both to our members and to the public at large. So we have a pretty good finger to the pulse of the sorts of questions people might have for these measures. And we sort of use that knowledge to come up with some FAQs here. And we're going to start with a couple specific to these SUPD statin use in persons with diabetes measure. So frequently asked question 1, how does SUPD account for individuals with statin intolerance? So this is a good question. I'm sure it's one that we're going to see in the Q&A chat. And really the main answer here is that individuals who don't receive a statin due to, say, a history of intolerance really are not expected to disproportionately affect one plan versus another. So remember, this is a health plan measure, which means it's a population level measure. We don't expect these situations really to happen disproportionately in one plan's population versus another, meaning that these cases and differences from a statistical perspective, when it comes to actually impacting performance, we expect them to come out in the wash, to use a common phrase. We expect those differences to be negligible or not significant. And the underlying issue here, as many of you know, really is coding related. So it is that codes aren't available that are sufficiently specific to this history of statin intolerance. So the limitation really is data and coding related when it comes to these individuals, since when we're talking about excluding, we really want to have a high degree of precision and confidence that we're removing these people for the right reasons, as opposed to just having them drop out of the measure for a sort of an ambiguous code and then maybe not receive the same standard of care that we would expect others to meet. So eventually, a solution for this, it is going to involve something like richer clinical data to account for individual patient nuance or shared decision-making, but that's a question that's not only for PQA as a measure developer, but also for programs in which the measures are implemented too. And it's a much broader question than we could address right here and right now. So another question that we get frequently about this measure is around the proxy. So is the use of diabetes medication, specifically we're talking about 2 prescription claims here in the context of SUPD, is that an accurate proxy for diabetes diagnosis? So PQA certainly did not just sort of decide on this in a vacuum and then carry forward with it. As with all our measures, these specifications were developed in conjunction with expert multi-stakeholder input following our consensus-based process, and were also supported not just by conceptual input, but by testing. So use of prescription claims as a proxy for diabetes diagnosis was tested by PQA in partnership with multiple external testers. And what we saw there was positive. We saw that 2 prescription claims for diabetes medications on different dates of service, that is an effective proxy, and it accurately predicts diabetes diagnosis. And this is really important when you think about the context of this measure. You think about measures that, due to their inclusion in programs like the Medicare Part D star ratings, are going to be primarily based on prescription claims data, at least as far as the eligible population goes. So whenever you're able to do this with prescription claims, as opposed to requiring a medical diagnosis, you're going to make the measure a much better fit for that type of program, since those standalone PDPs, Part D prescription drug plans, typically don't have access to that medical data, and that puts them at a substantial disadvantage. Moving right along, next we have another SUPD question. So how does PQA update measures that use diabetes medications when some products or classes receive additional FDA-approved indications in addition to use for diabetes? I think I saw something related to this in the chat or in the Q&A already, thinking about things like heart failure, those Flozins that Rachel talked about, or weight loss. And this is a really good question because there is not necessarily a one-size-fit-all approach to these sorts of situations. We really need to consider these medications with multiple indications, disparate indications, on a case-by-case basis, and any changes that we make need to go through our consensus-based maintenance process. And there are a couple sort of tools in our tool bag that we can use to address this. We can address them by excluding members with prescription claims for these medications. This might be appropriate when we anticipate that switching between medications could cause the appearance of non-adherence, for example. There's also removal from medication lists. And then there's what we call the wait and see approach. So we want to wait, see what the prescribing patterns are, do some testing to understand the scale of the impact, because often as these new indications come out rather, it takes time for there to be utilization, and we need that utilization data to sort of get a better understanding of what's going on. So a couple specific examples. One common example, again, Wegovy is an FDA-approved branded product for weight loss. So we do exclude medications rather that are FDA-approved and branded for another indication like weight loss from the diabetic medication list. So those would not be included. And similar, those Flozin medications, dapagliflozin and pagliflozin, are also removed from those medication lists. And the rationale there is that, as I mentioned on the previous one, what we're trying to get at with these prescription diabetes medication claims are the proxy for diabetes diagnosis. So if these medications have multiple indications and we're not confident it's really for diabetes, we think it might be for heart failure, then that medication's not appropriate for use in that way anymore. So that's a very important consideration. So this refers to a recent change that some of you may have seen go through the rulemaking process recently, but it deals with the liver disease exclusion. So why was the liver disease exclusion for the statin use in persons with diabetes measures refined to just be cirrhosis? And isn't that a little bit too restrictive compared to how it was, which was just a broader liver disease diagnosis? And this is a question that I think really gets to a key point, and that is the difference, or rather the focus of these measures is to hone in on the most recent available clinical evidence and guidelines. So in this case, the evidence is pretty clear that the risks to liver from statin are extremely low, and that they don't outweigh the broad cardiovascular and hepatic benefits that are offered by statins. So what's on the slide here is almost verbatim from recent review literature and from guidelines. And as the evidence changes, as measure stewards, we have to change the measures. And we know that it takes some time for prescribing practice to change, but I think part of the hope with these measures is that as we keep them up to date, they can continue to push prescribing practice towards that guideline concordant care. So again, this change is completely rooted in the evidence, and the most recent evidence is pretty clear about this balance of risks and benefits and how it comes down in favor of the statin, except when you have a patient who is in cirrhosis, and in that clinical condition, the benefits and risks change, of course. And I believe we have one more on statin use in persons with diabetes, and saving a very important one for last. So statin intolerance, right? That might not occur disproportionately at the health plan level, but what about an individual provider? What about a clinician practice? And this is a super important point that I don't think we can emphasize enough. The difference between health plan and provider measures is substantial. The SUPD and PDC statin measures are specified for use at the health plan level of analysis and not the provider level of analysis. Measures really should only be used for the level of analysis for which they are tested, specified, and endorsed, because the fact is they might not actually be reliable or valid when applied to other settings. So if you think about it a little bit in this case, when we apply a measure like SUPD to providers, first of all, providers have a much smaller sample size in terms of patients than a health plan does. So those small sample sizes could cause SUPD to become statistically unreliable, meaning it's not able to make good distinguishments between providers in terms of quality. Or these situations that we talked about where a patient might have a history of intolerance to statin that are statistically irrelevant at a health plan level might have a greater impact when we're talking about a smaller number of patients at a given clinician's practice. So this difference between provider and health plan level measures is really important to understand. I believe that's the last of our SUPD. So Rachel, I will pass the baton to you to talk a little bit about the other measures.
Yeah, can you hear me? Hopefully I'm unmuted, I think. Okay, so moving on to some frequently asked questions, excuse me, related to our proportion of days covered statin measure. So, and we get a similar question to the one that Ben addressed earlier around a statin intolerance. The response is a little bit more nuanced or different here. The question is, how does the proportion of days covered statin medication measure account for individuals who are statin intolerant? And the short answer is that this particular measure does not account for individuals who are statin intolerant. And as Ben mentioned previous to the statin use in persons with diabetes measure, we do not expect that any one plan would be disproportionately affected by this more than another. Also, I think it's important to note that we do require 2 claims for a statin medication to get into the denominator of the measure. And so someone with intolerance to a statin would eventually drop out of the denominator over measurement years. If an individual is rechallenged with a different statin, if they receive a second fill and discontinue due to ongoing intolerance as well, they would likely not be included in future measurement years. All right. And then another question that we have frequently received about both of our statin-related measures is related to exclusion alignment. So the question is, why are there different exclusions between the proportion of days covered statin measure versus the statin use in persons with diabetes measures? So at first, I think I just want to make sure that we're aware the intent of the measures are different. So the proportion of days covered statin or PDC statin measure is more about adherence. Adherence to the measure infers ongoing adherence to appropriate therapy using the 2 prescription claims to identify that ongoing therapy, versus the statin use in persons with diabetes. That is an appropriate use measure that focuses on identifying individuals for whom the statin treatment is appropriate and whether that treatment is provided. So they are different measures. They do have different intent. And then when we think about the goals of denominator exclusion criteria, we have to think about the fact that the exclusions are meant to evaluate and help us have a population or sample in the measure, all of whom share a similar profile in terms of their likelihood of meeting the numerator criteria. And so we have a couple different things that we think about when we are considering a denominator exclusion. And those items include evidence that that exclusion condition occurs with a high frequency or such a frequency that it would distort the measure results. within the denominator exclusion, and evidence that the denominator exclusion significantly improves measure validity. And then we also consider evidence of empiric and base validity when we're considering those exclusions to move through our consensus process. Examples of evidence that would exclude or distort measure results include, but are not limited to, frequency of occurrence, variability of exclusions across providers or health plans, and sensitivity analysis with and without the exclusion. So hopefully that addresses that question a little bit. And I think now I'm going to turn it back over to Ben to talk a little bit about the equity considerations for the statin measures.
Yeah, thanks, Rachel. And I think any discussion of these measures would be incomplete without thinking a little bit about equity through this lens. Equity, is a major strategic priority for PQA, as well as, of course, the health system as a whole. This is something we've specifically called out in our Blueprint 2025, which, is a strategic document that really guides PQA's initiatives and activities, over the next few years. And we've really made a commitment through that document and sort of through our work planning to championing equity and to addressing health disparities in medication use quality. That really has become an important part of our mission. And we know from existing data, we know from existing research that disparities exist in medication use. That's not some secret. And we can draw all sorts of lines that we want to sort of uncover or reveal those disparities, whether we're drawing racial lines, age, income, gender, or all sorts of other SES or SDS or SDOH, social determinant of health related factors. We can see that there is differences in performance along those populations. And there are a lot of ways to try to address this. But one of the ways that PQA has been investing a lot of thought and time in, certainly not the only way, but one way that we want to highlight today, is by focusing on stratification. And stratification really refers to reporting separate rates for subpopulations of interest, right? So the purpose here really is to shine a light on disparities, identify these opportunities for improvement. And identifying this in a research context is a way to start. It's very important, but it's also definitely a priority to work with programs to consider how they can implement stratification. And that ends up becoming, a very complex topic with a lot of hard questions. Are stratified measure rates reported publicly, or are they reported just to accountable entities for internal awareness and quality improvement? So what's the right balance in terms of transparency to patients versus fairness to accountable entities? What about instances where we have a lot of patients, but we end up with small sample sizes because we're cutting them across all these variables and subdividing them? What about the reliability challenges that result from those small sample sizes at the subpopulation level? So these are tough questions that require a lot of thought, and they require a balanced multi-stakeholder approach, which I think PQA is well positioned to take, and certainly we have a lot of experience with. So that's certainly the pathway we're going to try to take. This is also an area of major interest. It should come as no surprise from CMS, as reflected in their work in that impact assessment that I spoke about just a couple minutes ago. So here on the slide, we do have some analyses that they ran on 2018 data. This was in the analytic appendix of the most recent impact assessment. And they essentially ran analyses on disparities across a large number of variables, across a very large number of measures, including the PQA statin measures. And as you can see here on the slides, the disparities do exist, and learning more about what drives these disparities, the differences in both the disparities and what drives them across measures, you can see very interestingly, the disparities are not the same for cholesterol, which is PDC-Statin adherence, and SUPD, which again sort of underscores what Rachel was talking about. Even though statin is in the name of both of these measures, they're fundamentally different concepts. One is about appropriate use, so it's starting individuals on a therapy, and one's about adherence, which is continuing that therapy. So it's clear that there are some different barriers in place for those two different activities. So really learning more about this, learning more about these differences, and most importantly, what sort of next steps PQA can take to try to close some of these gaps in advance equity. That's really the sort of information we hope to glean from stratification activities moving forward to help carry through and fulfill that promise that we've made to keep advancing equity in this area. So I will pass it back to Lisa here, but I think that we'll be hearing some questions from you all.
Thanks, guys. You already answered some of the questions that have come in, but I might reiterate a couple of them just to make sure see if you have any add-on information to provide. So yeah, we have about 10 questions here. So thanks everybody for your engagement. The first question is the rhabdomyolysis and myopathy exclusions are coded annually, but why are there not any approved history of rhabdomyolysis and myopathy codes?
Yeah, and I'll jump in here, Lisa. And this gets a little bit to what I spoke to just when I was talking about the statin intolerance. And this question of why there aren't any, I think is interesting and is the right question, because certainly I can speak for Rachel and Lisa and I when I say our lives would be a lot easier if these very specific codes did exist, because we do need very specific codes of this specific history of intolerance to meet the need that we have. But unfortunately, that's something that PQA can't control. Unfortunately, we don't create or maintain ICD as a universe of codes, or CPT as a universe of codes, or SNOMED. So those are actually stewarded and maintained by their own organizations, whether or not that's the World Health Organization for ICD, or whether that's the AMA for CPT, National Library of Medicine for SNOMED. But unfortunately, the new codes are added over time, but that's something that PQA would certainly support lobbying for these types of codes. But unfortunately, we're limited by the tools we have right now. And unfortunately, that's just not one of the tools that we do have as far as codes.
Thanks, Ben. And then I think this was covered. Have we considered removing Saxenda or Wegovy or other GLP-1 agents from the SUPD measure? But then also, what if there's off-label use for weight loss of medications? How do we address that?
Yeah, sorry about it. I mean, it's unfortunately we cannot take into account necessarily off-label use of medications across any of our measures. And so, we've done the best we can to kind of sharpen a dull sort of instrument, but we cannot take into account that. So unfortunately, it's just absorbed. But again, I do not know that there would be one plan disproportionately affected more than another in that circumstance.
Thanks, Rachel. This is another one for you, Rachel. Are there any plans to include other lipid-lowering medications with proven cardiovascular benefit besides the statins, such as the frequently asked about PCSK9 inhibitors to the statin use in persons with diabetes measure?
Yeah, that's a great question. I mean, we can certainly consider new appropriate types of medications that might be appropriate for treatment in a diabetic patient population. However, if they're asking specifically about the PCSK9s, the clinical evidence around improved outcomes is not necessarily what we would consider rigorous, and we might need a little bit more information that would support that consideration, and we could definitely take that back through, but at this point it's not something we have recommended for addition.
Yeah, and largely that measure is based on the clinical guidelines too.
Yes, very true. The clinical guidelines. Thank you, Lisa.
So I'm going to ask, I think that you could probably answer this, Ben. If you don't have prescription data for an entire year, would it be bad to calculate PDC for a shorter measurement period, such as 90 days?
Yeah, so this is an interesting question. And a lot of times the answer here is it's going to depend on the context. So in a research context, using the PDC methodology over a shorter amount of time is going to give you an estimate. You have to understand that it may be an incomplete estimate, but it does give you an estimate that might be useful for your research purposes. A period as short as 90 days, I would recommend in your individual case to be careful given just consider the type of medication and the fill patterns. With many chronic meds, you're talking about one fill over 90 days. So the PDC is not going to tell you a whole lot, but if you're looking at proportion of days covered for something with very short 7-day fills or something like that, that could be useful. So yeah, PDC is a flexible tool. It can be used in a lot of different ways. Our way is sort of the most stringent because it's being used in accountability applications. We want to make sure everyone is working from a complete picture, but in other applications might be appropriate.
Thanks, Ben. So this is a good question. While the measures are focused at the health plan level, health plans in an effort to move the needle, reward medical groups and provider groups for their performance. Do we see at PQA an opportunity to make provider-specific measures in addition to health plan or pharmacy measures that we're developing?
Yeah, I can start out here, and I'd imagine this is one that might have some input from all of us. Darren, really interesting question. And this is a measurement scenario, right, where larger entities sort of waterfall these incentives down from the plan level to smaller levels, whether those are health plans or. Now, does PQA see an opportunity to make provider-specific measurements in addition to the pharmacy-specific measures? Now, this is a good question because these two situations are similar in a lot of ways, right? We see these incentives flowing down to a smaller unit via these value-based contracts, right? So plans are generally establishing value-based contracts with providers or with pharmacies in some way, or it might be a different structure like DIR. But essentially, they're holding them accountable to these measures that maybe weren't necessarily intended. I think that the challenge with developing provider-specific measures will be similar to the challenges we are tackling in the pharmacy space, which is that these measures would not be able to solve the problem if we just threw them into MIPS, which is the merit-based incentive payment system. It's a physician CMS quality program for those who aren't familiar with it. What we're talking about are contracts between providers and health plans, and CMS doesn't really play in that space, and that means that it's the health plan that's in the driver's seat. So PQA could create those measures. Then the question is, where is the motive or the leverage for them to be used in these contracts? And that's a question that we've worked through and spent a lot of time working through on the pharmacy side, but it's important to sort of understand the context of that. And that's sort of my thoughts off the cuff here. I'm sure Lisa and Rachel could provide further input. Or they can say, good answer, Ben.
Good answer, Ben. That was actually a very thorough answer. Thank you. So, Rachel, related to the PCSK9 inhibitors, we talked about, could they account for numerator compliance for the SUPD measure? There's a similar question. Is there a consideration for adding an exclusion for members who cannot tolerate statins but are receiving treatment with a PCSK9 inhibitor? And there's a note here that this is similar to NCQA's SPC measure.
Yeah, sorry. So it's a good question. The last that I knew, NCQA was considering this for the SPC measure, but it was not necessarily implemented. And so, we always try to have harmonization where we can. I'm not sure that we are considering this particular exclusion at this time, but it is definitely something we can think about in the future.
Thanks, Rachel. So for statin use in persons with diabetes, the primary data source is PDE, or prescription drug event data. Is this data available for use and review?
Yeah, so that's a really good question. And the good news is that CMS does do a very good job of making their data available to researchers. You're going to have to deal with some delays. I think that the most recent available data is 2018 or so, but there's an organization called ResDAC, which you can work with to get through the process of obtaining various different specifications of a number of CMS claims file, including the Part D PDE file. So that could be a 5%, could be a 20% sample. They have a variety of years involved. So that would be the organization to go to work with that data if that's your interest. That's RESDAC, RESDAC.
Thanks, Ben. And then kind of along the lines of identifying exclusions, since there's no specific history of code for rhabdomyolysis and muscle intolerance codes, would we ever consider having a longer look back to prior years as some other quality measures? So exclusion code in the measurement year or the year prior, for example.
Yeah, that is a great question. We have tossed that around internally quite a bit, and I just want to say that it's something we're considering. We have to assess the feasibility of implementing that, and it would have to go through our consensus process, but it is certainly something that we are considering.
Thanks, Rachel. We did want to let you guys know that we did put the population health article in the chat, the link to it, as well as looks like there's a couple of links there. And I have a question about the weighting of the SUPD measure. Why did it go from 1 to 3 to 1?
Yeah, so the short answer here is that CMS weights measures in the star ratings according to the measure type. So process measures are weighted 1, outcome measures or intermediate outcome measures are weighted 3. And then actually technically there is a third category, which is that the improvement measures are weighted 5, although those are sort of their own measures. And the reason that SUPD has been jumping around has been related to those classifications. So initially when it was weighted 1, it was considered a process measure, but then for a bit, CMS considered it an intermediate outcome, and notably the PDC measures, so those adherence measures that are in the star ratings, are also triple weighted as intermediate outcome measures, and that is going to stay the same. But in response to sort of their own internal conversations and some feedback, CMS is reclassifying that measure as a process measure. That is something that the PQA team is aligned with. We do view that as a process measure. Again, sort of drawing that distinction between that as an appropriate use gap closure measure versus adherence, which really is a different measure and is much closer and very, very well correlated, as we've demonstrated with that impact assessment, with those outcomes, and really is considered an intermediate outcome. So that's a little bit of the reason for the winding history of SUPD weighting.
Thanks, Ben. Another question is there a consideration for excluding members from the SUPD measure who have an LDL below 70?
Yeah, that's a great question. And I just want to do a quick call back to remind everyone what data are used to calculate those measures. And so we use prescription claims data, and then we also use medical claims to identify exclusions from the denominator. So we are unable to have lab data available to us at this time to be included in that measure. So at this point, that is not a consideration for the existing measure. But, you know, as we move forward and we might have other types of measures, you know, and access to different data, then that might be a different consideration.
Thank you. And one person asked about why is there a difference between the medication lists for related to the diabetes medications for the SUPD measure for identifying that eligible population, and then the adherence measure to diabetes medications? Why are those not aligned?
Yeah, also a great question, Lisa. I can take that one. So I understand why people feel like they should be similar, but remember the intention behind the measures are different. So, and when you think about the specificity that you would need to identify diabetic patients for a gap closure measure, you might have to be a little bit more restrictive in that list as opposed to adherence measure, where somebody who's on the diabetic med, regardless of diagnosis, it's more about they would still be required to be adherent. So the medication where there's real kind of differences between those two measures are, I think insulin is excluded from the proportion of days covered diabetes measure. And that is excluded from that measure because there are frequent dose adjustments that happen with insulin that make it difficult to calculate the day supply. And there's also currently no standardized method to assess adherence to insulin using prescription claims data. So that's why insulin is not included there, but it is included in the other measure. And then also the recent information we shared on the dapagliflozin and empagliflozin is also somewhat different in that it's removed from the medication list, as we mentioned previously, for the SUPD measure because of the multiple indications that make it less likely to be a sufficient proxy for diabetes for the SUPD measure. Hopefully that helps.
Thanks, Rachel. So we're going to start wrapping it up. We did get a question about how to license the PQA measures. So I'm going to ask our meeting organizer to drop the link to our website in the chat. And we would like to sincerely thank PerformRx again for being an educational sponsor for this Quality Essentials program. You can learn more about PerformRx at performrx.com. And please join us for our next Quality Forum webinar on Thursday, July 21st from 1 to 2 p.m. Eastern. We will be joined by Curator, who will share pharmacist-led virtual care model and its impact on patient outcomes. The registration link is available in the chat, so please make plans to join us that week in July. And as a reminder, please share your feedback on today's webinar by responding to the survey that will open at the conclusion of the webinar. We very much value your feedback and use it to shape future programming. And thank you for all of the questions and engagement. We really appreciate it.